Welcome to the Explainer. Okay, today we are diving headfirst into the fascinating, and yeah, let's be totally honest, completely overwhelming world of orthopedic nursing. If you have ever felt totally lost in a sea of medical terminology while just trying to figure out how our bodies break and heal, you are exactly in the right place. Let's strip away all the confusion and look at exactly what happens when bones, muscles, and ligaments are pushed way past their limits. Look, if studying ortho makes you want to literally tear your hair out, trust me, you are not alone. There's this meme going around that just hits the nail on the head. Nursing school be like, just a few simple musculoskeletal concepts, followed by, you guessed it, a sobbing emoji. It feels like learning a totally different language, right? But hey, we're gonna fix that right now by breaking everything down to the absolute basics. So, here is your holy grail, the ultimate ortho cheat sheet. Memorize this and your life gets so much easier. Bones, those are just the hard parts. Joints are simply where two bones meet up to party. Ligaments, think of them as super strong straps holding bone to bone. Muscles, well, they do the heavy lifting to actually move those bones. And tendons are like the ropes tying the muscle to the bone. So basically, the whole shebang works like this. A muscle pulls a tendon, the tendon pulls a bone, and the bone moves right at the joint. It's actually beautifully simple. And suddenly, all those injuries finally make sense. Seriously, let's look at the classic mix-up, sprains versus strains. A sprain is all about the ligaments, those bone-to-bone straps. Like when you wince and say, I rolled my ankle. That's a sprain. A strain, though, that's an injury to the muscle or tendon itself. Think of someone grabbing their lower back and groaning, man, I pulled my back. Knowing this difference, it's a total game changer for how you look at these everyday injuries. So how do we handle those sprains? Whether it's a mild grade 1 or a gnarly, fully torn grade 3, we fall back on the classic Rice method. You probably know it. Rest the joint, hit it with ice right away for 24 to 72 hours, just 10 to 20 minutes at a time though. Compress it with an elastic bandage, but obviously please don't cut off their circulation. And finally, elevate it. This basically gives that ligament a safe little bubble to heal up with scar tissue. Okay, let's dial up the intensity a bit. What happens when the bones themselves start shifting? Well, if you have a subluxation, the bone has just partly slipped out of the joint. It hurts, for sure, but it's manageable. Now, a full dislocation, that means those poor ligaments stretched, tore, and the bone completely popped out of its socket. We see this all the time with shoulders, knees, ankles, even jaws. And listen, popping a true dislocation back in is not some action movie DIY trick. It usually requires a formal reduction, literally popping it back into place, often under anesthesia. But what if the trauma is even worse? That's when we leave soft tissue behind and get into the actual hard parts, fractures. And wow, bones can break in just a dizzying array of ways. You've got closed fractures where the skin miraculously stays intact, and then the really scary open fractures where the bone actually violently breaches the skin. And the patterns themselves, you might see a transverse break going straight across, a spiral fracture from a nasty twisting force, or a comminuted fracture where the bone literally shatters into tiny pieces. To fix these, we've got to lock things down. For your standard break, a traditional plaster or fiberglass cast does the trick. But what about those massive open fractures where the tissue is just destroyed, or if there are severe burns involved? That's when you bring out the external fixation device. This is pretty hardcore. We're talking about drilling metal pins directly through the skin into the bone and attaching them to this rigid external frame to hold everything absolutely perfectly still. Now, here's an absolutely crucial takeaway for patient care, especially when you're working with those old school plaster casts. The drying phase is critical. First, let the patient know they're actually going to feel some warmth as that cast sets. It's totally normal. But here is the big red flag. You have to protect that fresh cast from getting dented. Never, ever put a fresh cast on plastic. And seriously, never cover a wet plaster cast with a blanket. Even a tiny bit of uneven pressure while it's drying can cause massive circulatory issues or nasty pressure injuries right underneath. So what if a cast or fixator just won't cut it? Enter traction. This is where we literally use weights to pull fractured bones back into a straight line. There's skin traction, which is definitely less invasive. It just uses splints or tape on the skin with weights pulling from there. But then you have skeletal traction, which is highly invasive. They actually drive a pin, wire, or screw straight into the fractured bone itself and hang the weights off that. Oh, and the golden rule for any traction setup? Those weights absolutely must be hanging freely at all times. No exceptions. Okay, once everything is finally stabilized, the body takes the wheel. And our internal repair system, it's kind of miraculous, honestly. But it is definitely not fast. Between weeks 3 and 8, this soft, squishy callus that formed over the break slowly gets resorbed and turns into harder bone. From there, starting around week 4 and sometimes lasting up to an entire year, the bone goes through this massive consolidation and remodeling phase. The exact timeline really just depends on how bad the break was, plus the patient's age and overall health. It's like watching a really slow, amazing construction project. It literally starts as a hematoma, just a big pool of blood right at the break site. Then that morphs into the soft callus we talked about. Next comes osteoblastic proliferation, which is just a fancy way of saying a massive construction crew of new bone cells swarms the area. Finally, we hit that long remodeling phase, where the bone reshapes itself. By the end, you look at an X-ray, and sometimes it looks so perfectly repaired you can't even tell it was ever broken. But things don't always go perfectly according to plan, right? Sometimes healing just hits a brick wall, and we call these union complications. You might see a delayed union, which is exactly what it sounds like. It takes way too long, but it gets there eventually. A non-union means the fractured ends just stubbornly refuse to fuse together. And a malunion, that's when the bone does heal, but it heals crooked or malaligned. To get things back on track, doctors might throw everything at it: daily low-intensity ultrasound, electrical bone stimulators, or even packing in bone grafts from the patient's hip or a donor to kickstart the healing. And then we get to the truly bizarre stuff. Have you ever heard of heterotopic ossification? This is wild. It's a condition where bone literally starts growing where it has absolutely zero business being, like deep inside muscles or soft tissues instead of your skeleton. It happens a lot after a massive hit to the soft tissue, like a really bad contusion. We see this all the time in young guys after extreme sports injuries. It is super painful, stiffens up the joints, and if it completely ruins their mobility, a surgeon might actually have to go in and carve that new bone right out of the muscle. Okay, but of all the things we see, the absolute most terrifying complication in orthonursing is hands down compartment syndrome. Imagine an unrelenting internal pressure cooker. Basically, swelling gets so out of control that it starts crushing the nerves and blood vessels trapped inside a muscle compartment. The tissue literally starts dying. The dead giveaway? Severe agonizing pain that doesn't even budge when you push heavy narcotics. To save that limb, they usually have to do an emergency fasciotomy, slashing long, deep surgical incisions straight into the leg just to instantly pop that pressure. Because this is a massive medical emergency, you have to be totally obsessive about assessing for the 6 Ps to catch it early. Okay, ready? First is pain, specifically pain that is totally out of proportion to the actual injury. Second is pallor, so pale skin. Third is paresthesia, which is that weird pins and needles feeling. Then pulselessness, paralysis, and finally, poikilothermia, which is just a fancy way to say the limb feels physically cold to the touch. If you miss these, you are risking permanent, irreversible muscle and nerve damage for your patient. Wow. Okay, we have covered a ton of ground in this explainer today, from the super basic cheat sheet of how we move, all the way to the intense interventions required when things go sideways. So, now that we've decoded all the scary medical jargon, I want you to think back for a second. Think about your own life. Based on our little ortho cheat sheet, what was actually happening under the skin during your last big injury? Were you dealing with a strained muscle pulling off a bone or a sprained ligament desperately holding a joint together? Because honestly, truly understanding the mechanics of your own body is the very first step to protecting it. Thanks for joining me for this explainer, and keep asking questions.